How you doing, man?
Hello, everyone.
Hi, Erika. Hi, Lauren. Thanks for presenting. We'll give everyone to 1:05, then we can start.
No problem.
Testing. Erika, can you hear me? Okay.
Yes, I can.
Okay.
Erika, I got to run in to do a really quick procedure. So if you want to start at 1:05, that'll be fine. And then I'll log back in.
Okay, no problem. Can everyone see my slides?
Yep.
Yep.
Yes. So I guess I'll get started. And if other people want to join in the meantime, they can join along and hopefully join in the discussion. I've planned this talk to be kind of interactive. So I'm hoping people will be willing to discuss some of the things that I'm going to talk about in this particular lecture. So we only have 5 cases today, and I've asked Lauren, our PEM fellow, to join us for one of the cases because it was hers, and then hopefully we'll be able to have a discussion and figure out some cool, or at least look at some cool images. So our first case is the case of a 7-year-old male who came in with a complaint of abdominal pain. He had no significant past medical history, was otherwise well, and came in with a complaint of abdominal pain since the day before in the morning. He had a history of constipation, so parents were thinking probably this is his usual constipation-related pain. So they sat on it for a day or so before realizing that this pain wasn't going away and wasn't his typical constipation pain. So they brought him in for further evaluation. So he's not had any fever throughout all of this, no vomiting, and he was complaining of pain when he goes over bumps in the road. His pain was 6 or 7 on 10, but when he lies down, he said his pain was 15 on 10. And the pain was mostly in the periumbilical and right lower quadrant region. So when he arrived in RED, these were his vital signs. So in RED, he was actually afebrile, but significantly tachycardic and had a respiratory rate of 28. And he was alert and looked unwell. He looked like he wasn't feeling so great. And, you always have to worry when the 7-year-old is sitting in the bed and lying super straight, not moving. You always worry that there's something going on that might be concerning. So I used to hate abdominal pain a whole lot, but since I started ultrasounding, it's actually a lot more interesting for me because even the teenage girl with abdominal pain, I find now interesting because I can scan them and try to narrow down my differential. It's become a thing for me to sign up for these patients quickly and see what I can find. So here's what I found. This is the linear probe in our bowel setting. It's in the right lower quadrant, and you can see he's pretty lean, and what you're looking at is basically a bunch of inflammatory change kind of in this area here, and then here's the appendix coming down, and then there's this huge thing coming what appears to be off the appendix. So here's it is in the longitudinal view. There's a big bladder, and you can see this this crazy structure right here. So looking at that, I did some measurements, and that's what it looks like. Approximately it's 0.55, distally closer to 0.8. And I'm curious if you guys had seen these images, what you would say.
I mean, like with his presentation and stuff, we think it almost looks like a walled off abscess, like almost like a ruptured abscess, like a abbey, or like that's walled off or something.
Yeah, definitely looks like an abscess, right? And tons of inflammatory change. I'm going to go back for a second. Tons of inflammatory change, and oops, I'm going backwards. Tons of inflammatory change, big abscess looking thing. So, for me, that was slam dunk. This kid looks sick enough. If it looks like a duck, it walks like a duck, quacks like a duck, is it really a duck? So we sent it over to radiology, obviously, because the surgeons aren't going to do anything in our institution without a comprehensive scan, which is not unreasonable. And here's what the radiology read is. The appendix is enlarged with mural thickening, hyperemia, periappendiceal inflammatory change, and there is a heterogeneous collection measuring 2.2 by 3.7 by 2.5. And their impression is acute appendicitis with findings concerning for perforation because of this heterogeneous collection. So the kid went off to surgery, had his appendix removed. He was admitted. He had an elevated white count at about 22. And when I was preparing for this session, I was going through all my old scans and super interested in what actually the outcome was and how they ended up managing this kid. And I had waited long enough that actually I ended up looking at the path report, and this actually was not a ruptured appendix. This was a normal appearing appendix with it was actually an infected urachal cyst. And so you could have fooled me. Like, I would have no idea. I've never actually seen this, you know, presenting so much like an appendicitis. And I think in this image, you can almost see a tract coming off the bladder, actually. And it's, you can see the tract like over here coming off the bladder. And so I just wonder whether that was the tract that might be the you know, the pathway to the bladder. But I think if I fool myself as well, it looks like there is a path from the appendix to this urachal cyst as well. So I don't know if we would be able to tell that sonographically at all. Has anybody seen this before?
Erika, was it fairly midline, you would say, in terms of both the longitudinal and transverse?
Nope. This is very clearly right lower quadrant. We had every single finding for appendicitis that is in the textbook. Like, we're talking Rodsing signs, obturator sign, psoas sign, and it was definitely right lower quadrant, not suprapubic. And I'm actually sad. I don't know if Henry, you're back on, but and part of this, Kate as well, you might recognize this one. This actually isn't. This is like published ahead of print, and the urachal cyst that Henry reported on was actually suprapubic, and it was a very midline picture. And this one was very right lower quadrant. So it certainly fooled me, and it fooled. I'm happy to say, also fooled the radiologists. And I think it's just important to keep in mind that even though it looks like a slam dunk abscess, that all these weird sort of neonatal remnants are still a possibility.
Hey, Erika, Dave
Yeah.
Taggart, just had a quick question. Embryologically, how does that even work?
I don't know. So
Yeah, I'm
maybe
just
you
trying
can
to
tell
think.
me.
Yeah, no. I'm trying to think about it, right? Because I mean, I guess anything's possible. I'm just trying to think. I know this is a great case. I'm just trying to think embryologically what would make the urachus be not
Right
midline.
lower?
Right.
Yeah, it was not midline. It was not midline. And I wish I could pull up the picture that Henry I should have put in the picture that Henry published in this paper. But the one that he describes is really just superior to the bladder and adjacent to the bladder. This one, and this is on path report too. And when they looked at it on intraoperatively, they were very clear that the appendix actually looked normal, and that this was clearly a urachal remnant.
Yeah, we've had a couple, and they've all been very midline suprapubic, and
yeah.
And you know, I think the last one we had was, you know, mom even gave a history of intermittent fluid coming from the belly button at times, and she didn't really think anything of it because it never was persistent. Yeah. And I'm just trying to, you know, I'd have to pull out my embryologic books, but I'm just trying to figure out how that would happen. Meaning, like, is there a defect in the abdominal wall cavity? You know, I'm just trying to figure out how that would even happen.
Yeah, because this one, if you look here, I mean, pretty clearly, like, this is transverse, the transverse projection. This is the psoas muscle right here. You can see the two iliacs, and you can see the appendix coming almost like exactly where it should come off in this area. And then there's this like huge thing that, honestly, look, it looks like it comes like, it's like immediately adjacent right here to the appendix. So you could have fooled me. And I, you know, if I hadn't thought to go look up the path.
Is there something that's also attaching to the abdominal wall? Like,
you're thinking like a hernia, Adam?
No, but like right there. I want to pause this on my screen, but I can't.
I know. I don't think I can even wait here. Let me see if I can pause it.
Like right there.
Like here, right?
Yeah.
Like over here. It's possible. Like, is it?
I mean, you may be right lower quadrant, but where this window is maybe closer to midline than we think.
Yeah.
And your
Erica,
7 o'clock region, there looks like there's a communication there, or
Yeah.
yeah,
Here.
right. Yeah.
Well, that's why I was thinking that it was an abscess. So I was
Yeah.
thinking it didn't even, urachal cyst did not cross my mind. And so I agree with you that this might be something that is, a communication somewhere.
no history of umbilical hernia, right? Or
No, healthy kid. I think he had a hydrocele repaired as a baby, but that was it. But I mean, you really could have fooled me.
Erika, for clarification, was radiology reading your images or did they obtain different images as well?
Nope, they were reading their own images.
Their own images. It's interesting it wasn't even on their differential because I feel like usually the radiologists will, propose
hedge,
what's most
right?
likely, but say it could also be X, Y, and Z, that it wasn't on their differential either.
Yeah. So, yeah, I thought that was kind of interesting. I'm glad to see that everybody else is as floored as I was with this diagnosis. And honestly, I never got feedback on this case. And if I wasn't preparing this talk, I don't think I ever would have known that it was happening, like that this happened.
Yeah, it's super cool images, Erica. For me, one of the things, I mean, I would have been thrown off obviously as well. On some of the clips where you're fanning, it almost appears like there's symmetry in the degree of thickness of the cystic structure and the outer portion, the wall portion. So some things that cross my mind when I see things like that is like rare hernias, like Spigelian type or other type hernias. I would have not have thought urachal if it wasn't midline at all. So thanks for sharing. This is pretty wild.
Cool, right? Then I was like, hey, I should publish this. And then I came across Henry's. I'm like, well, maybe, I don't know. So beat me to it.
You can publish
All right.
it right lower quadrant though.
Yeah, I can't publish it like urachal cyst remnant mistaken for, appendiceal abscess. So I think maybe it'll come up. Kate, it might come across your desk somewhere. Okay. Let's go back. Okay. So our second case is the case of a child with abdominal pain. So he's a toddler. He was 19 months old and was well until about 10 days earlier when he started developing cough and congestion. 3 days after that, he was diagnosed with COVID. The whole family had COVID, and they all had to do their quarantining, and his symptoms resolved 1 day later. No cough, no congestion anymore. He was feeling pretty good. So he was well for about a couple of days. And then 2 days prior to presentation, he developed what seemed like intermittent abdominal pain. What the dad said was initially the pain seemed like it was intermittent. And now it was becoming more constant, and he was fussy and just very difficult to settle. The patient was 19 months old. So what the dad describes is that he was holding his belly, he was complaining, and the dad said that his belly felt hard. Last bowel movement was earlier that day, soft, no history of constipation, and no fevers. And he's had decreased oral intake over the last couple of days because of this pain. So what are you guys all thinking?
Urachal duct cyst.
So I go in with my ultrasound because my thought is this is totally intussusception. It's got to be intussusception. So I heard the presentation about this kid and I walk in with my ultrasound. I was convinced I was going to find an intussusception. So this is what I see. So I always start transverse, right lower quadrant. And so here's psoas muscle. Here is the two iliacs over here. And then there's some like maybe bowel, something going on here. And then I see this in the right lower quadrant. So I'm seeing like, lots of inflammatory change, number one, and then this structure that looks kind of circular in the right lower quadrant. Very lean kid and a little bit tough to scan because he was 19 months old and had some belly pain. What does everyone think? You're scanning this patient and that's what it looks like. I'm going to show you one more. That's longitudinal. What's the diagnosis?
He had no history, right, Erika? You said there was nothing abnormal in his history.
Just COVID. COVID like 10 days earlier, URI symptoms resolved, and then now with this pain. Now I'm gonna, so kind of put that in your mind, and we can go back to them later if we need to. So then I completed the rest of the ascending colon. Looks sort of like that. And then the transverse and descending colons were pretty normal looking. What do you think? I'm going to go back to this one. Intussusception. There's a lot of crickets in the room, so I'm sensing that people are either skeptical because I'm asking the question, or they're not sure.
I mean, it looks like there's a lot of like inflammation going on there, almost like, I might be completely wrong, but like maybe like a vasculitis type of picture post-COVID or
It's a good thought, right? Because normally with intussusception, we don't see that degree of inflammatory change.
Yeah, almost like a vasculitis post-COVID like type of thing. I don't know.
Some of them look like there might be a little stalk even, like in some of the views. So I'm wondering if it's like matted, like large lymph nodes, but that's sort of not the normal.
It'd be pretty big, right? Like we're talking, it's like 3-4 centimeters, I guess, in its biggest. So I struggled with this quite a bit, and then the kid ended up getting called to ultrasound. So I had to stop my ultrasound because I knew that this, when I was in the room, I was kind of like, okay, so maybe that's a pseudo kidney in the longitudinal. It looks kind of kidney-like. I was like, where's the kidney again? And it had this like circular sort of pattern to it that might be intussusception, but it wasn't the clear target with like small bowel in the middle, large bowel on the outside that I was super comfortable with saying that this is intussusception. So there's that ascending colon. Here's the radiology read. So the ultrasound tech gets the scan and the pictures look identical to ours. And the radiologist who looks at these images says this is a short segment ileocolic intussusception in the right lower quadrant. And so radiologist comes in from home and is, preparing to do the air enema, and they rescan him before the enema. And here's the reread. So they say, while the terminal ileum is mildly thick-walled, no ileocolic intussusception was demonstrated sonographically. And the cecum is now decompressed, lots of right lower quadrant lymph nodes. And so they did not do any air enema on this kid. So the kid ends up getting admitted, and we were like, oh, so maybe he self-reduced or something, because from my impression, it was really short segment, so maybe he self-reduced or something like that, right? And so again, follow up for this presentation. I followed up on this kid because I just really, the findings were just really weird for intussusception. So the kid ended up getting admitted, still had ongoing abdominal pain while he was in house, and they ended up CTing him, and they found that he had an appendicitis. actually. And all of that was bowel inflammation in relation to a ruptured appy. So, you know, this is the comprehensive scan image. And, you know, the radiologist didn't comment on it at the time, but, you know, retrospectoscope, obviously. So this is the thing that we saw that I was like, maybe that's a weird pseudokidney. But like this looks like an unmistakable appendicitis right here that nobody had commented on in the comprehensive scan. And then you've got a lot of, you know, surrounding inflammatory change. And now it all makes sense. The degree of inflammatory change on that scan was pretty remarkable. And so when I went to go see the radiologist to discuss these scans, and I said, when you looked at that and read it as intussusception, were you looking at it saying this was slam dunk, or did you have some hesitation? And she said she definitely had some hesitation, but I guess they have to call it something. So she said, you know, reading the images from home, that's the best guess that she had. But when she had the probe in hand, which really makes a difference as opposed to having a tech scan, she was like, this is not intussusception. So I think that these are my scans towards the end of my scans. And I think that I probably did catch the appendix down here. Not enough time to interrogate it and too fussy a child. So, you know, there's a downside to pre-scanning these kids before you send them to ultrasound, which I think you know, is a fair complaint by the radiologist, because in this age group, trying to get them to cooperate for the scan is a big deal. And so I didn't want to, you know, tire him out too much, but I think probably this is what it is. So that was an appendicitis in a 19-month-old. And it's funny because I always talk about how this is the age you're going to miss it in. And when you see this age group and you see belly pain in this age group, always think about appendicitis, because when they come in, they're going to be late stage and often more likely to be perforated. And certainly that's been my clinical experience as well. And we didn't even get, you know, we were thinking going down the intussusception route. So we didn't think there was any chance that this was going to be appendicitis. So we didn't even get a white count. I don't think anybody got a white count, actually, even when he was admitted. So that's all a fair warning in those 19-month-olds. Always think about appendicitis. And if there's that much inflammatory change, maybe not intussusception. And bowel edema. I feel like I always get tripped up on bowel edema. This has come up like probably 3 times in this group. Like bowel edema is something that we should just be scanning, so we start looking at the images and getting used to them. Any comments on that before I go on to the next case? All right, Lauren, you are up. This is Lauren's case. So this is, I'll let you tell the story, Lauren.
All right. So this is an interesting case that came out of my ultrasound rotation month. So I'm gonna preface this by saying this was like one of the first ultrasounds I ever did. But on a Saturday morning, I get a text from Erika saying that she reviewed one of my ultrasounds. So she had been sipping her coffee, reviewing some images. You want to go to the next slide?
Yep.
And this is an abdominal ultrasound that I had done just for educational purposes. And I had gotten this transverse view in the right lower quadrant. Anybody want to comment on the findings we're seeing here? Yep, ring of fire. Yep, there's a ring of fire sign in the right lower quadrant. I saw this like targetoid structure. This is a teenage patient, and I was kind of like, wow, what is that thing that I'm finding here? I've never seen anything like that before. I don't know. I'll ask Erika about it later. Do you wanna show the next one? And then this was the that was the transverse view. This is a longitudinal view. Again, just like looking at this structure that I'm seeing in the right lower quadrant, you're seeing it's very tubular shaped. Yep. There's some inflammation. I did measure it and got it at about a centimeter. I don't have that still saved, but so I recorded it, I saved it, and you can go to the next slide, Erika. And when Erika was querying it, she obviously immediately diagnosed this as appendicitis. And when she was reviewing the chart to follow up on it, she saw that the disposition for this patient was discharged home with a diagnosis of gastritis. So let's go into more of this story. You go to the next slide. So she was reviewing these images, which had been taken 4 days prior. So the story on this patient is that as a 15-year-old male who was presenting with 5 out of 10 periumbilical and epigastric pain that had just started the night prior. He did have a past medical history of gastritis. He had a positive COVID contact. He had one episode of emesis that day, but wasn't showing any other infectious symptoms, no fever, no URI symptoms, no diarrhea. So this patient, next slide, please. Was evaluated. He was very mildly tachycardic, but was afebrile, and his exam was only significant for mild tenderness in the epigastrium. Next slide, please. So in his ED course, he received a GI cocktail, just like symptomatic treatment for his abdominal pain. I rolled into his room to perform an educational ultrasound just because it was part of my rotation. And then after he had received the GI cocktail, he was symptomatically improved. He was able to PO, and he was discharged home. The assumption here was that he has a known history of gastritis. He had been treated for it previously. It was epigastric abdominal pain that improved with GI cocktail. So we thought clinically correlated with his known history of gastritis, and so he was discharged home. Next slide, please. So Erika texted me and said, did you know what you saw in that patient? And I said, no, I did not know what I saw in that patient. And she said, well, that is a very clear-cut appendicitis. So she reviewed the imaging with our radiology department, and the radiologist agreed that it looked suspicious and recommended that we call this patient back. So we called him back to the ED for a comprehensive scan and a reevaluation. So in the 4-day interim from when he had been discharged, he reports that for the first 2 days after that discharge from the ED, he was febrile to a Tmax of 102. And then the subsequent 2 days, he had been afebrile. He was completely asymptomatic at the time of his recall. He would not have represented to the ED except for our call asking him to. And in the ED, he had a normal physical exam, but given the findings on the previous scan, he was sent for a repeat comprehensive ultrasound. So these are the still images from the radiologist's ultrasound of the right lower quadrant. So you can see it's less inflamed. I think on the next slide, there's a picture of the distal tip measuring. So they were measuring somewhere between 0.5 and 0.7 centimeters, so a little bit generous at the distal portion, but they weren't calling it an appendicitis. And if you go to the next slide, it was not vascular, not hyperemic like it had been in my scan. So if you go to the next slide, luckily at that time, he was found to have a normal appendix. And they were saying that I'm seeing COVID, viral appendicitis. Yeah, we were a little stunned by this case. We were kind of confused as to why someone could have had like a florid appendicitis and self-resolve.
So I was curious as to what the group would say. If they were the ones image reviewing this, looking at those images. Can you convince yourself that it is a normal appendix in those first scans?
No.
No. When I talked to the radiologist, I had to be brave to like send my images over to radiology. But when I talked to them, what they did say is that sometimes color can be a little bit subjective. And if your gain is too high, you can make anything look hyperemic. So he's not super confident with the color portion of the, even though it looks like the ring of fire, and he absolutely would have called this patient back based on those images. The tip of the appendix looked much more inflamed on that initial image than on our image. So either this is a self-resolved weird appendicitis, or it never, like he just has a generous appendix that fooled us all initially. Has anyone had anything similar to this? I don't know. I feel like I've been doing this for a long time, and I still am very humbled by a lot of these images that I see. So definitely a lot of respect for radiology, where they're the last, I'm lucky I can cop out and say, I don't know what I'm looking at. Let's ask radiology. But radiology actually has to like make the diagnosis or make a decision as to what this is. And so I feel like, especially with appendix, we just have to maintain a really high level of respect for the appendix.
Can you go back to your images again?
Yeah.
So,
And
you mentioned that he was COVID positive a few days prior, or?
No, that was the previous case.
Oh, that was previous.
This patient had a COVID exposure, but he refused a COVID swab. So we don't know what his COVID status was.
Which one do you want, Matt?
Yeah, this is the one. Is this the only still you have?
This is the longitudinal appendix that we had. And then the one previous to that is the short. That looks, it looks like the ring of fire to me.
Yeah.
And Lauren mentioned in her QPath, she'd mentioned like this tubular structure has a maximal diameter of 1 centimeter, but she forgot to actually save the image. So I didn't have those images to look at or to see whether her caliper placement was adequate or not.
Erika, there's a ton of information on that, but I'm just wondering, were you guys, or Lauren, if you can speak to this, were you able to see the tip of it? Because the question then becomes, is it like a terminal ileum as opposed to the appendix? Because in 4 days without antibiotics for it to be normal. And of course, I'm just playing Monday morning quarterback because I think the images that you're showing me, I'd be very suspicious. But I'm just trying to figure out what other explanation we'd have.
That's why I was asking about the last image, actually, because I wanted to see if I could convince myself that that was a tip or not.
All I had to go on.
No, yeah.
These ones.
With what you had to do what you did. I'm just, again, like looking back, I'm just curious.
So my impression is that terminal, that's a good thought actually, but terminal ileum, my sense is you would at least get peristalsis if it was like, healthy-ish bowel.
Not all the time. Yeah, not all the time,
No?
Erika, especially because there's so much inflammation. I mean, if the kid had diarrhea, that's and a lot of the COVID cases we've been seeing, it looks like this, where you just have a ton of inflammation. And, being that it's so large, that's the only thing I can say is that maybe it is ileum versus appendix. Again, I think I would be exactly where you were at the time to say, this doesn't look right. But I'm just, again, trying to try to explain what this really would be. But the information is already concerning for me, irregardless of what everything else is. Yes.
So weird.
Someone asked if it was painful during scanning. I don't recall him really, giving me much trouble during this scan.
I don't know. It feels like this is like, you see it almost coming off the cecum here.
Yeah.
But I agree that, TI also comes off, in that main area, but in the short, so I like to look at TI in the short, and when you're seeing TI in the short, the inside of it looks more like a flower as opposed to like a target. And this one seemed like it was more target-like as opposed to like flower-like in short axis. So that was my thought. but I like the idea of thinking about that. And you know, a normal TI, if you put a little bit less pressure on the probe, it should bounce back to like almost 2 centimeters. And this bowel just, you know, in the longitudinal isn't collapsed at all. So I just wonder whether, you know, TI makes sense for this picture, but it's a really good thought.
Yeah.
I don't have a similar case like this one, Erika, to share. Just we have heard from our radiologists similar about hyperemia, how they feel it's likely the least specific of all the ultrasound findings for appendicitis. I do feel like the more that we do, the more appreciation there is for how heterogeneous the sonographic appearance of appendicitis is. And I mentioned this only because very recently I had a case of a thin 10-year-old girl who had a perfect story and well, not perfect, had a pretty good story for mesenteric adenitis and a pretty mild exam and mild leukocytosis, and an ultrasound where essentially there was a little bit of hyperemia to the ileum, a little bit of hyperemia to the appendix, a 5 millimeter diameter wall of the appendix that was visualized in its entirety. And the only finding that was really stood out was that there was free fluid by the appendix, but it wasn't just a small amount of free fluid. It was a good amount of free fluid next to the appendix, and she'd never had her period yet. So based on that finding alone, with a normal diameter, the decision was sort of, and this came from our radiologists who were really pushing for a appendicitis diagnosis, where the exam wasn't that, I mean, she had right lower quadrant pain, but it wasn't peritoneal, no rebound, nothing like that. She did not get a CAT scan. Our surgeons did a laparoscopy, and she had acute suppurative appendicitis, again, with a 5 millimeter appendix. So, you know, it's humbling.
It really is. I just have a really healthy respect for appendix because of all the, you know, all these cases that I'm presenting today are, you know, bowel pitfalls that you can come across. And so that's super interesting. Was that on PATH or is it on what the surgeons reported? Antonio, do you know?
I can double check the PATH. That was from the operative report, but I can double check the PATH.
Yeah, because I feel like one of the things I worry about as well is, you know, those post-op notes are so brief. They'll say like pre-op diagnosis, acute appendicitis, post-op diagnosis, same. And I always like to know what the PATH is just to get another, you know, another viewpoint on what that actually is. All right. Let me go back to our next case. Thank you, Lauren, for sharing that.
Thank you.
Okay, so our next case is the case of a 15-month-old kid who was standing on the bed the day before and he fell and hit his face on the side table. And mom came in because he had some bruising under his eye related to that fall and said, oh, by the way, he's also been pretty constipated. So I was wondering if you guys can help us out with that too. So this was a kid on a teaching side, and our fellow quite appropriately said, you know, she was about to send the peds resident in to go see this case. And she said, just whatever you do, don't order a KUB, because KUBs have very, very poor sensitivity and specificity for constipation. Constipation really is a clinical diagnosis. So, so the peds resident goes in and gets the history and comes out and tells our fellow the following, that the kiddo had a history of constipation, that he had been seen by GI, he had his usual cocktail of like Miralax and glycerin suppositories, and despite all of that, he has not had a poop in a week. And so he had some belly distension on the exam, but they couldn't like feel anything particular because he's 15 months old and was not cooperative with the exam at all. And so when the fellow heard this, the first thing she said was, let's order a KUB. And knowing that, you know, the KUB is not super sensitive. So I heard about this story and I had the recollection of this study that was done looking at transrectal diameter on point of care ultrasound to diagnose constipation in a child. And I'm of the same opinion that I don't like KUBs for constipation, only because I feel like you can interpret it any way you want, depending on what the clinical story is. So, you know, if you don't say anything to the radiologist regarding constipation, they might not even mention fecal loading at all. And if you really want there to be stool in the rectum, you can just imagine that it's there. So I try not to order KUBs to diagnose constipation. I like the clinical diagnosis thing. But I have been paying more attention because of this article, and Almaz was one of our fellows. I have been paying more attention to looking at rectal diameter on ultrasound when I scan these patients. So when I went to see this patient, this is what I saw. So on the left is the longitudinal view. And on the right, you can see the right lower quadrant transverse view on this. What do you guys think? So I can't see, by the way, I can't see the chat at all. So if anybody has something to say, someone tell me what the chat is looking like. What do you guys think is going on in the belly there?
Julie
give you
put
one
a
more.
smiley face and Antonio put toxic megastool.
It's a lot of stool, right? So here's it is in the transverse colon. You were still like going along the transverse, like as if I were to do an interception study. I mean, there's up in the transverse colon area, there's still a ton of stool. And here's the descending region where you're just seeing, like, again, some small bowel, but still either a huge mass or a ton of stool. So that's the KUB that was obtained by the fellow. And I think that the take-home point for me is that yes, constipation is a clinical diagnosis, but in certain cases, there's definitely some value to the KUB, because this picture just screams Hirschsprung's disease. And you know, that was the thing that I was worried about the most, with the size of the colon in this child. I was really worried about Hirschsprung's disease. And so I did some chart digging, and, you know, he had been seen by GI, and they, you know, GI's default is always like, let's try Miralax, let's try, you know, better stooling habits and all the usual behavioral stuff that they do. And they had, you know, he was between visits, so mom hadn't gone for the follow-up scan yet. And as it turns out, 1 year earlier, this is what his scan, his KUB looked like during an ED visit. That was the chief complaint, was constipation. And the official read on this one was large amount of stool in the rectum and ascending or sigmoid colons, and consider Hirschsprung's disease. But for some reason, that read got lost in the primary care. It got lost by GI. GI didn't even mention Hirschsprung's disease as part of their differential diagnosis. And that whole thing got lost. And when I tried to follow up with this patient a little bit later, after we had done those scans, you know, we admitted this kid for a clean out. He had a great clean out within a couple of days. He ended up getting Go Lightly by NG. The colon was completely empty by the time he was done. He was sent home with follow-up for suction rectal biopsy and barium enema, which they wanted to do both. And again, this patient was lost to follow-up, and he's so far scheduled for suction rectal biopsy on Monday, but still didn't get his barium enema. So I'm not sure if this patient is actually going to follow up or what the outcome is, but I'll certainly keep you posted on March 1st to see if he shows up for the appointment. When you read through this chart, this family has a huge long list of missed appointments and poor follow-up. So I'm hoping that he gets what he needs and will eventually get at least a diagnosis. Anyone seen anything like this before?
My question, Erica, is that does anybody still do a digital rectal exam?
The answer is yes, it depends. I did not do one on this kid. I do them a lot more in neonates. What would you expect to find here? Because what I would expect to find here on rectal exam, maybe I'll find a huge hard stool. Maybe I will find an empty rectum because he's got an peristaltic region there in the distal rectum. Tell me what you would think.
I think, I mean, the textbook answer is that you will feel very, very tight anal ring, but then again, I don't do them routinely, so I certainly don't have a good judge, you know, what's a abnormal tone. But I guess, again, you know, we don't use KUBs for constipation diagnosis either, and I try to convince my residents to do a digital rectal exam. They looked at me as if I'm crazy. Maybe the other reasons, but anyway, it's something we don't apparently do anymore.
Yeah, I think there's definitely some value. I don't know if it would change my management a whole lot in this particular case. All things being equal, definitely in the neonates I do, if they're coming in with a history of constipation, just because there's the risk of some sort of congenital defect is much higher in that age group. But it's a good thought for sure. All right. The last case of the day, I've got about 5 minutes. The last case of the day is an 8-year-old with a history of eczema who comes in with this new onset, like weird mass in the right sort of flank area. This is a picture of her back. And you can see her gluteal fold there at the bottom of the picture, and you can see she has quite a bit of atopic dermatitis. And right where mom is pointing, right there is this new mass that they had felt that started that day. And the story is that the patient had just started Dupixent. I don't know, I'm not familiar with Dupixent, but it's this new treatment that the dermatologists are using for severe eczema. It's an IM shot that is supposed to be given at home by the parents. So the story is that she got her Dupixent shot like the day or two before, and she had to be held down for her shot. But aside from that, there was no trauma to the area or anything like that. And she had this new painless mass to her right flank. And mom's concern was, does my child have cancer? So she goes to her pediatrician. The pediatrician looks at it and says, I don't know what it is. It's completely non-tender. There is no overlying erythema. Let's get it ultrasounded. So from clinic, they send her up to radiology. This was our resident clinic. They send her up to radiology, and these are the scans that they get of this area. So there it is in two different planes. It's this, like, I like to call it a lesion for lack of a better word. And here's the radiology read, which I love reading because it's so vague in its nature. Like my take home point is that when radiology doesn't know what it is, they just describe what they see, and that's totally fair. And I've actually started doing that myself when I kind of put in my read on POCUS into the chart. So their impression is hypoechoic collection without internal vascularity. Considerations include all sorts of stuff: hematoma, infection, soft tissue, necrotic soft tissue, histologic correlation is required. So we had surgery see this kiddo, and they were like, it's a hematoma, send them home. So the kiddo goes home, and with this diagnosis of hematoma, we don't know why her hematoma is that big. We did a basic coagulation workup, which was completely normal. She goes home, and then she comes back 2 weeks later, and I happen to be on again. And it's the same, the mom was like looking at me sideways, like, I can't believe you sent us home the first time, and great that I have to see you again. And so now she has this area of overlying erythema. And I remembered her from the last time. So I go in, I'm like, let's do the point of care ultrasound. So these are our point of care ultrasound pictures, which look remarkably the same to our first ones. Basically unchanged. The only difference is maybe there's a little bit more soft tissue thickness superiorly there on the superficially, but the internal contents basically look the same. And here is the short axis fan through the whole structure. It basically looks exactly identical. And so based on this, we call surgery again, and we're like, look, now there's overlying erythema. Tell us what you want to do with this. They're like, well, sedate her and we're going to do an incision and drainage. And so we sedated her, and she had an enormous amount of pus. So all of that internal stuff was all pus. And I didn't get to take a picture because they did it all without me there. But it was 100% thick, purulent stuff in there. And all of this is to say, you know, really, like these abscesses, I feel like we see so many things, and there's so much of clinical correlation that matters in this. I don't know, like between the first scan and the second scan, the only thing different to me in appearance is like the overlying erythema and the thickness. And even when surgery came down and said, we're just going to incise it and see what happens, I was like, really, do we think we're going to get pus, or is it going to be like clot? What's it going to be? And I was very, very surprised. So even to this day, I'm not sure if it was hematoma at the beginning, like maybe it was pus the whole time. Who knows? I'm not aware that hematoma can turn into pus. Does anybody know that? Anybody knows whether hematoma can turn into just thick, purulent fluid? But I thought that was interesting. I'm scanning, I feel like I always like to scan before I incise an abscess. But it doesn't necessarily always help me because there's still some that I hope I can get away with warm compresses or something like that. Any comments on that? Nothing? Nobody?
Well, thank you, Erika. That was brilliant.
Okay, I'll take that comment. I was hoping other people are like, yes, I've seen this. Isn't it weird?
Was that
I haven't
the
seen this
area
before.
she had her injection of the medication?
No.
Oh, that wasn't. Oh.
Nowhere close to where her injection was. It was like some random weird spot. No family history of MRSA, no family history of, no personal history of abscesses, just random collection of stuff that, who knows?
No blood, or it was just purely pus, right?
Just all pus.
I'm curious.
I don't know. I feel like
I'm curious if we did like a POCUS after we drained it, what we would see, like, if there would be anything to see, evaluate.
that's a good question. I didn't even think to ultrasound it after the fact, but that's a great question. My guess is it would be like inflammatory change, maybe some cobblestoning or something. That was a big collection though. All right, folks, it's 1:59. And if anybody hasn't been to Second Beach in Middletown in winter in a pandemic, I have to say that if you have some time, this is the place to go. There are sand dunes that collect over the winter that are not there, and you can walk on them. And it's very beautiful. That's all I got.
Thanks, Erika. Sorry I couldn't, I was in the middle in and out, but I unfortunately had a busy department. But I was hearing the endings of the cases, so I'm definitely going to watch it. Thanks for presenting.
No problem. Have a good rest of the day, everybody.